First of all, let me introduce myself. My name is Tallafigo, and I'm a medical oncologist at the University Hospital of Jerez de la Frontera in Cadiz, Spain. I'm going to give a presentation about a clinical case in which I want to highlight the importance of adequate diagnosis in lung cancer and the transformative impact of Idylla EGFR in thoracic oncology. This is a case involving a 65-year-old Arab woman with no toxic habits, diabetic under treatment with metformin, dyslipidemic under treatment with simvastatin, history of thyroid surgery over 20 years ago for non-tumoral pathology, currently on replacement treatment with levothyroxine, and a laparoscopic cholecystectomy. In October 2023, the patient visited her primary care physician due to coughing, night sweats, and fever, for which she was prescribed antibiotic treatment. Due to the patient's lack of improvement, a chest X-ray was requested, in which an increase in density can be seen in the right base. For this reason, the patient was referred to a pulmonology team and a chest CT scan was requested. The CT scan revealed a right parahelial lesion with cystic necrotic content as well as mediastinal lymphadenopathies. Here on the right side of the slide, the CT slice, we can see a subcarinal lymph node. There is also a right pleural effusion and a lytic lesion at the level of the spinous process of lumbar fourth. This leads us to a clinical diagnosis of probable metastatic primary lung tumor, and due to this reason, a bronchoscopic with biopsy and a diagnostic thoracentesis were performed, with both samples sent to pathology. The biopsy material, was insufficient for diagnosis, but the cytology of the pleural fluid was helpful, showing cytological findings consistent with adenocarcinoma. Thus, we obtain a diagnosis of metastatic lung adenocarcinoma due to pleural and bone involvement. This was presented at a multidisciplinary tumor board, and it was decided to evaluate the quality of the pleural fluid sample to see if a mutation study could be conducted, as well as referring the patient to medical oncology. 3 days later, the patient was attended oncology consultations, presenting dyspnea with moderate exertion, headache with alarm signs, and lower back pain. Given that the patient was very symptomatic and the high suspicion that the patient had a potentially druggable mutation, adenocarcinoma plus female plus never smoker, a rapid PCR was requested, awaiting NGS, as well as a brain MRI. Previously, the pathologist informed us that the sample had a high tumor cellularity, making it of good quality for analysis. Here we have the result of the cranial MRI showing a left occipital bone lesion, and as for the result of the PCR panel, we see that the patient has a mutation in EGFR, the lesion of exon 19. So treatment was started on November 23 with osimertinib. However, a few days later, we received the result of the NGS, which did not detect any potentially druggable mutations presently. Nonetheless, the patient rapidly improved with treatment, as well as radiologically. Therefore, the patient truly had a mutation in EGFR.